Hello everybody, this is Dr. Abdurrahman Shqaidif. I'm going to today to talk about orthodontic assessment. In order to do a proper treatment planning for your patient to get these results, or from here to here, you should be able to do a proper diagnosis for your patient. So you're going to do examination, then collect these data, then analyze it, then go for a problem list, aims of treatment, options of treatment, and then inform consent and go for the definitive treatment plan. So today we're going to start this by talking about orthodontic examination. So we start with the history. So what we're going to ask our patients. Reason of attendance. So what is the patient attending the clinic? The patient should be given the chance to describe their problem in their own words, meaning if the patient said that I don't like the aesthetic of my teeth, that would be a big umbrella. That could be the color, could be the shape, could be the alignment. So basically we need to be very specific and asking the patient to describe them the way he described it, not the way we do it. So if the patient is concerned about the appearance, if concerned about the dental health, is he concerned about the function, speech or eating, so the patient has to mention exactly why he is here. Or is he referred from other departments, for example from prosthodontic department to do an ortho restorative treatment that we will cover later during this semester. Or and we should be careful of this kind of patient who doesn't know why he is here. Maybe mom wanted him to do a braces. In these cases we need to check if the patient is cooperative in our treatment or not. We have to check medical history, identify any aspect that might affect orthodontic treatment. This is the one table is the relevant medical history. It's in the Laura Mitchell textbook. It would be good to have a quick look at it. The most important two things is the nickel allergy and the bisphosphonate patients, because our material has nickel, so we have to be careful. In bisphosphonate patients, we can treat them with orthodontic braces. We have checked dental history, how many times the patient attended the clinic, because that can affect our treatment. If the patient is a regular attendee, that means that the patient is cooperative. If the patient did not attend the clinic for 2 or 3 years, that means the cooperation might be an issue and we might find a lot of caries. If a patient has a root canal treatment, we need to check that as well. If the root canal treatment is good and there's no periapical radiolucency, then this is fine. But if this root canal is due to trauma and the trauma resulted in root resorption, we should be careful about that, because these teeth might be resorbed even more during the treatment. However, if there is no resorption, that should be fine. We have to check habits, and the most important one is thumb sucking habit, because it causes proclination of the upper incisors, retroclination of the lower incisors, and asymmetrical anterior open bite. We have to check as well for the patients and the motivation and expectation for the treatment. So basically, if patient has a problem with his jaws, that can be only corrected by surgery, and he expecting that the orthodontic treatment will correct it, then that would be a problem at the end of the treatment, because braces can only fix teeth and we can't fix jaws. Social behavioral factor. So if patient is living far away and we need to do braces, we should consider making the treatment time maybe longer and see him less often, trying not to force him, for example, to drive 2 hours to come to the clinic. For example, if he's treated in Ajman, he's living in the Al Ain, that would be a lot of commute, so try to make less visits for these kind of patients. So now we finish the history, we move into the clinical examination. We divide clinical examination into extraoral examination and intraoral examination. When we get into the extraoral examination, we have to check the skeletal relationship, we have to check the smile aesthetic, soft tissue, and the TMJ. So start with the skeletal relationship. First things first is depending how we posture the patient's head. So if you can see, this is the same patient, all right? So in the first one on the left, the patient is tipped her head downward. That means that she look like if she is a class 2. While in the one on the right, she is tipped her head backward and the chin moved forward. And according to this photograph, she is a class 3. But this is not correct because she's not in the correct position. Now, how we position the patient, we call it the natural head position, where the patient look at the horizon, okay, and this is where we assess the patient profile. Sometimes we ask the patient to look into the mirror. It's the same. Make sure that the patient is sitting and look flat. We call this a physiological position because the determinant of this position is a physiological one. Always have to think about the patient in 3 planes. We should not think about him in 1 plane. So we have an anteroposterior plane, we have vertical plane, and we have transverse plane. And there's where we examine our patients. So for example, this is the what we call it the anteroposterior relationship. So you examine if the patient is a class 1 or a class 2 or a class 3. This is the relationship between the maxilla and the mandible. This is an anteroposterior dimension. And this is we look at the vertical relationship. So we look at the lower facial third and compare it to the rest of the patient thirds. We look as well to the transverse relationship between comparing the right side of the face to the left side of the face to see if the patient has any kind of asymmetry as well. That's what we call it a transverse problem. So this is how we should examine our patient: anteroposterior, vertical, and transverse. So this is the first one, second one, and third one. So starting with the anteroposterior relationship, usually the maxilla should be, that's what we define it as a class 1, and all of you are expecting to know the terminology and the definition in the clinic. So class 1 means the maxilla is 2 to 3 millimeter in front of the mandible. Now what represents the maxilla is we call it the A point, which is the deepest concavity of the anterior surface of the maxilla. What represents the B point is the mandible is the B point, which is the deepest concavity into the anterior surface of the mandibular symphysis. So you can see this is the A point, this is the B point. The difference between them should be 2 to 3 millimeter, and that's when we call the patient as a class 1. If this difference is more than 2 to 3 millimeter, then we are talking about a class 2 patient. If the difference is reversed, where the mandible is the head of the maxilla, we call this as a class 3 skeletal relationship. One way to detect the A and B point is to use the index and middle finger. How do we do that? If you look, usually the index finger is shorter than the middle finger by 2 to 3 millimeter. So if you approach the patient touching the A point and the B point, if the index and middle finger touches the A point and B point at the same time, it means that the difference between them is 2 to 3 millimeter, and that should be fine. But if, for example, the patient is a class 3, you can see that the mandible is positioned more anterior, so the middle finger will touch the B point before the A point, and then the head will be tilted counterclockwise. And that's going to tell me that the patient is class 3. This is one way to help you in the clinic to decide if the patient is a class 1 or class 2 or class 3. Now then we have to decide what is the etiology for this class 3. We use something, we call it the zero meridian line. So we drop a line from nasien, and that line should be perpendicular to the floor. The chin should be sitting on this line plus minus less than 2 millimeter. So if the mandible is within this range, that means that the mandible is in a normal position. But if the mandible is sitting far posterior to this line or far anterior to this line, that means the mandible could be retrognathic or prognathic. So zero meridian line tells you the correct position of the mandible in relation to the cranial base. The other method to assess is, we call it the assessment of the convexity of the face. So we look at the glabella, subnasally, and Begonian. So glabella is the most prominent part between the two eyebrows. Subnasally is the junction between the base of the nose and the base of the nose, and the junction between the philtrum and the columella. Begonian is the most prominent part of the mandibular chin. So usually, patient who has a convex profile, as we see in the left, this is a class 2. While straight profile, but with a little bit of convexity, as we can see here, is up to 15 degrees, we still call this one as a class 1. The concave one is a class 3. Hello. And the second dimension we check is the vertical dimension. So what do we look at? Now we look at 2 things, using the rule of third to divide the face and to measure the angle of the lower border of the mandible to the Frankfurt plane to assess what we call it the growth rotation. So the rule of third, basically you divide the face into 3 thirds. The first one, the hairline, then glabella, then subnasally, then menton, and this is not Begonian like we did with the facial convexity. Okay, So this patient should have an equal thirds. All right, so the lower facial third should be equal to the middle facial third, and sometimes this lower facial third will be reduced. Now, the mandible has a growth rotation. We have two types of growth rotation. It's either going to be as the top photograph, downward and backward, or as the bottom photograph, upward and forward. Now, if you have a patient with downward and backward rotation, what are we expecting? That the mandible will go back. So that's mean that it will patient be more into class 2. The distance between the upper and lower incisor will increase, so that's mean that the patient will be having either reduced overbite or anterior open bite, and because the mandible is going away from the maxilla, we are expecting the patient to have increased lower anterior facial height. Opposite thing will happen if the patient has an anterior growth rotation, so the mandible will move upward and forward, the lower facial third will be reduced, deep overbite, and more into class 3. However, this is not always the case. This is what likely to happen, but not all the patients with anterior growth rotation will have a reduced lower facial height, because sometimes that will be compensated by increase in the length of the ramus, so we're having an increased posterior facial height, and we will not have a reduced lower anterior facial height. Or for example, if the patient has a posterior growth rotation, you are expecting to have an anterior open bite, but the upper and lower incisor compensate by over eruption and the patient have normal overbite. How do we examine growth rotation? We look at the Frankfurt mandibular plane angle. Frankfurt plane goes from the canthus, the orbitali, which is the lowermost point of the orbit of the eye, and touching the external auditory meatus, the porion, the uppermost point of the external auditory meatus. With the mandibular plane, which represents the mandible, if these two lines meet just posterior to the ear, that means that the patient has a posterior growth rotation. While if these two lines are almost parallel, that means that the patient has anterior growth rotation. That's why I'm telling you about the anterior growth rotation. If we look for Carol Smaha, for example, this is the Frankfurt mandibular plane angle. And if you can see, the Frankfurt, she has an anterior growth rotation, but she does not have a reduced lower facial height. And why is that? Because the ramus, if you can see, she has a square face. Sometimes they call it Texas face. She has increased in the ramus length that resulted in anterior growth rotation without even affecting the lower facial third. So not all patients with anterior growth rotation will have reduced lower facial height. They most likely will do, but not always. As you can see here, she has an equal lower facial thirds. Transverse relationship, so basically we draw a line that is divide the patient's face into right and left, and using this we compare the right side of the face to the left side of the face and see any asymmetry with the face. We detect usually the obvious asymmetry. We don't look at mild asymmetries because all of us are kind of asymmetrical to some point, so we need just only to check the obvious asymmetry. Sometimes we use what we call it the paired view, in which you look at the patients from the top and you can check where is the chin going, either to the right side or to the left side. There is something we call it the rule of fifth. Basically, you look at the patient and you divide it into 5 parts. From the outer side of the ear to the outer canthus, from the outer canthus into the inner canthus, then from inner canthus on one side to the inner canthus on the other side, then outer canthus and outer side of the ear. All these fifths should be equal, and the chin should be in the middle of the middle fifth. That's another way of doing it. However, just remember, whenever you evaluate the facial asymmetry, we completely ignore the nose, because sometimes the nose will be tipped to one side, and that should not affect your assessment. Then we look at the smile aesthetic. We look at the amount of the incisal show on smiling, and if we have a gummy smile or reduce or increase incisal show on smiling. We look at the buccal corridor and see if a patient has a consonant or non-consonant smile. Then we look at the soft tissue. What do we look at the soft tissue? We have to examine the lips and the tongue. The lips should meet together. The definition of a competent lips, that the lips should meet together at rest without or with minimal muscular activity. So the patient should not exert a lot of muscular effort to bring these two lips together. How the lips will be brought together? If with a muscular activity, there will be a stretching of the mentalis muscle. And you can see here that the labiomental fold is kind of obliterated, and that we have dimpling of the muscles of the chin. That's telling you that the patient is exerting a higher muscular effort to bring these two lips together. So competent lips, the lips need minimal muscular effort to bring the two lips together. Incompetent lips, patient has to have a muscular effort to bring the two lips together. As you can see in this photograph again on the A and B, A, the patient is relaxed. B, as you can see, she's forcing the two lips to meet together. This patient as well can see the labiomental fold on the right and on the left, how is it completely obliterated. The patient is exerting force to bring the two lips together. So why is it important to know the lip competency? Because basically and simply, all of us have to achieve an anterior oral seal in order to be able to swallow food. If you can't achieve anterior oral seal, you can't swallow food. So how to do that? Simply, patient has to bring the two lips together. If they are competent, they will meet easily. But if they are not competent, what's going to happen? The first method is what we call forced lip swallowing. So basically, you are forcing the upper lip to touch the lower lip and achieve an anterior oral seal. We call this forced lip swallowing pattern. Then, if we have an increased overjet like this with reduced lower facial height, the patient can't force the lips together. So what it is going to do, the lower lip will be trapped behind the upper incisors, as we can see. So then the lower lip is touching the palate. We call this lower lip to the palate or lip trap, because the lip is trapped behind the upper incisors. And this is how the patient achieves anterior oral seal. When the patient has a lip trap, the end result that the upper incisors will be proclined, lower incisors will be retroclined, and the end result will be an increase in the overjet. The other method of achieve anterior oral seal, we call it tongue thrust, or lower lip to the tongue, or tongue to the lower lip. So basically, the lower lip jump above the teeth and go to the lower lip to achieve anterior oral seal. And this can cause an anterior open bite and proclination to the lower incisors. We should examine the nasolabial angle, which is the angle between the philtrum and the columella. Usually the normal value for that is 90 to 110. Just remember, nasolabial angle is measuring the relationship between the maxilla and the nose. So basically, if this angle is increased, that could be because the upper incisors are retroclined, the maxilla is retrognatic, or the tip of the nose is elevated. So remember that this angle is affected by the nose position. Tongue should be examined as well. We have two types of tongue thrusting. Tongue could be sitting normally in its place, but sometimes we have what we call it endogenous tongue thrust or adaptive tongue thrust. The endogenous tongue thrust, the patient will have a big tongue that is sitting between the teeth all the time. Usually this happens with the syndromic patients, and this one will result in anterior open bite and proclination of upper and lower incisors. The other one is the adaptive tongue thrust. So patient has an anterior open bite. Here the tongue is being the good guy and jump between the upper and lower incisors to achieve anterior oral seal. You have to examine TMJ as well, and I'm sure that you have done that a lot in the other clinical aspect. You check the maximum amount of oil teeth opening, tenderness of the muscles of mastication, clicking and crepitus, all of that should be recorded. That's the first part. Now we're going to move to the second part of the orthodontic assessment, which is talking about the intraoral assessment. So what is the intraoral assessment? We start with the examination of the oral health, then stages of the dental development, then the assessment of each dental arches, and the last one is assessment of arches inclusion. So start with the oral health. If patient has gingivitis and periodontitis, that should be noted. Patient has any caries, that should be noted as well, as just regular and normal charting that I'm sure you are all familiar with. Don't forget to mention teeth with poor prognosis and the quality of the teeth presented. Then we mention stage of dental development. So we look if the patient is in the primary dentition where all the teeth are primary teeth, or if the patient is the mixed dentition where the lower sixes, lower incisors, then upper incisors start to erupt. So we're going to have now primary and mixed and permanent teeth. Then the patient will go into the full permanent dentition, when in the lower arch the second premolar erupt, and in the upper arch the canine erupts, and now there's no any primary teeth. Then we start assessment of each dental arch individually. So we look at the upper arch and lower arch, and what do we assess? First of all, we assess the degree of crowding and spacing. Could be mild, moderate, and severe, and I'm sure you have done that a lot last year in the lab. And then we see any displaced or rotated or ectopic teeth that should be mentioned. So for example, here the canine is erupted not in its position, so we call it ectopic. So what is the definition of ectopic tooth? Tooth that is erupted in position that it's not where it should erupt. Impacted, tooth that is prevented from eruption by bone or soft tissue or any obstruction. Then we have to check the inclination of the teeth. So we look at the teeth, usually upper incisors should be 120. Make sure that if they are retroclined, like in here, or proclined, you have to measure them. So how to look at that? We look at the upper incisors to the Frankfurt plane. Usually it should be 110. So if it's more than that, it's proclined. If it's less than that, it's retroclined. So we have to mention if they are proclined, average, or retroclined. And lower incisors should be 90 degrees into the mandibular plane. So look at the mandibular plane. Lower incisors, they should be 90 degrees to the mandibular plane. So it should be proclined, average, or retroclined. Then we have to check the angulation of the canine, and that's very important in our treatment. Usually the canines are slightly mesially angulated, okay? That's the angle of the canine, okay? That's the normal angulation. If they are more mesially angulated, then that means to get them back to their normal position, we can only move them with tipping movement, which means that we can reuse removable appliance. So again, if you want to decide whether you can treat this patient with removable appliance or fixed appliance, you need to know one of the things that you have to look at is if you can do only tipping movement. If you only can do tipping movement for this patient, then you can use removable appliance. Once you start need bodily movement, then you can do a removable appliance. So if at the start of the treatment, the canine was really mesially angulated, so you can tip it back to its normal position. But if the canine is distally angulated at the beginning of the treatment, you can't use a removable appliance to correct this canine because it's already distally angulated. And if you're gonna distalize it, it's gonna the crown go distally and the root gonna go mesially even more, hitting the lateral incisor. So this patient can't be treated with a removable appliance. And that's why in a lot of textbooks, when you read it, one of the indications to use removable appliance is a mesially angulated canine. We have to check the arch shape and symmetry. So usually we look at the arch shape and we see if there is any asymmetry in one side or the other. We have usually U-shape arch form, and we have to mention that. Symmetry, for example, if we have in the lower arch, as you can see here, the lower 6 on the right side is mesially migrated due to the premature loss of primary E, while on the left side, if you can see that the E is still there and the D is there, so the 6 is far more posterior than or distally compared to the right side. This is kind of asymmetry that is resulted from premature loss of primary tooth. Then we have to do assessment of the arch in occlusion. So we have to look at the incisor classification. Class 1 is when the lower incisal edge is occluding with or lie immediately below the cingulum plateau of the upper incisors. While class 2, where the lower incisors is posterior to the cingulum plateau, and this can be subdivided into division 1, where the upper central incisors are proclined or average and the overjet usually increased, or division 2, where the upper incisors are retroclined and the overjet usually reduced. Class 3 is the opposite, where we have the lower incisal edge anterior to the cingulum plateau of the upper incisors. Then we have to look at the canine and molar relationship, and here we have I don't like to memorize it, but I just like to understand it. So basically, let's start by looking at the canine relationship. So canine relationship class 1, the upper canine should be in the embrasure between the lower 3 and lower 4. So what we need to do is just to memorize class 1. Now, if the patient has a class 2, that means that the mandible will go backward, right? So to have a class 2, the mandible will go backward to the point where the upper canine will be between the 3 and the 2. We call this a class 2 molar. Class 3, what's happening is the opposite. The mandible will move forward to the point that the canine will be between the 4 and the 5. And here we call it a class 3. So only what you need to do is just to memorize the class 1 canine. However, if the canine did not move the whole distance, just only half of it, that we call it cusp to cusp or half unit class 2. Or if it's a class 3 direction, half unit class 3. That's how we measure half unit class 2 and class 3. What about the molar relationship? The molar relationship that when the mesobuccal cusp of the upper 6 occlude in the buccal groove of the lower 6. Again, we only need to memorize this one. If the patient is a class 2, then the mandible will go back to the point that the distobuccal cusp will occlude in the groove and the mesobuccal cusp will be in the embrasure between the 6 and the 5. If the patient is a class 3, that means that the mandible will move forward to the point where the cusp of the upper 6 will occlude in the embrasure between the 6 and the 7, and the buccal cusp of the 5 occlude in the buccal cusp of the lower 6. Half unit again is a cusp to cusp relationship. So if you can see here about the half unit thing, the mesodistal width of a canine, we call it 1 unit. The mesodistal width of one cusp, for example, the mesobuccal cusp, is called 1 unit. So if the canine now in the embrasure here, we call it class 1. While if the canine move half the distance toward its final relationship to be class 2, it moved only cusp to cusp, we call it half unit class 2. If it's moved 3/4 the distance, we call it 3/4 unit class 2. And if it moved the whole distance, we call it a class 2. So here is a class 2 where the whole movement is happened into class 2. And here, if it's moved only half the distance, it's only cusp to cusp, we call it half unit class 2. And if it's moved the full distance or 3/4 distance, we call it a 3/4 unit class 2. Same as in the molars, if here it's called the class 1, if it's moved until here it's called class 2, as we can see, and if it's moved half of the distance and we have cusp to cusp, we call it a half unit class 2. Then we have to measure the overjet, and remember when we measure the overjet, our ruler should be horizontal and it should measure the maximum overjet that we get. Okay, so if you have 2 teeth with minimal one overjet, we pick the biggest overjet. Then we have to measure the overbite. So overbite, when you describe it, we have to describe 3 things. First is the degree of the overbite, and that's measuring the amount of the overlap between the upper and lower incisors. Normally, the upper incisors should be covering only 1/3 of the lower incisors, as we can see in the top photograph. We call this normal overbite. However, if the upper incisors is covering less than 1/3 of the lower incisors, we call this a reduced overbite. But if the upper incisor is covering more than 1/3 of the lower incisors, we call this deep overbite. So it's kind of first description of the overbite, if it is normal or complete or increased. Then we have to measure, the previous one is either it's normal, as in the top one, reduced or increased. Now then we mentioned about complete or incomplete, traumatic or atraumatic. So what's the meaning of complete? That there is a touch between the upper and lower incisors. Incomplete, that there is no touch between the upper and lower incisors. Traumatic means that there is a trauma, meaning either attrition between the upper and lower incisors, or atraumatic means that there is no attrition or no ulceration to the palate. So as you can see here, sometimes deep, complete overbite can cause ulceration to the palate, and we call this traumatic overbite. Now we can have the opposite, which is anterior open bite, where there is no overlap between the upper and lower incisors, and in these cases we have to measure the amount of the overlap, that is the amount of the anterior open bite, and the extent from where to where. Center line, you have to measure the center line of the face and decide the relationship of that to the upper incisors, then the lower center line and related to the upper center line and the midline of the face. So sometimes we have the upper is shifted from the lower, and you have to decide on the relationship of the mid of the face. Then we have to look at the crossbite. Now, crossbite definition is a discrepancy in the buccolingual relationship of the lower and upper teeth. And there are 3 features that we should consider when we assessing crossbite. First, we should mention if it's buccal or lingual. So our reference is usually the lower arch. So if the buccal cusp of the lower occlude buccally to the upper cusp of the upper, that means that we have a buccal crossbite. While if the lower cusp of the buccal cusp of the lowers occluding palatal or lingual to the palatal cusp of the upper, that's called a lingual crossbite or a scissor bite. Remember that the reference is usually the lower arch, so that's how we describe it, buccal or lingual. Then you have to mention if it's anterior or posterior. So here, this involving the posterior teeth, that's called a posterior crossbite. While sometimes it's involving the anterior teeth, so we call that as an anterior crossbite. Then we have to mention if it's unilateral or bilateral. So this one is affecting one side, so we call it a unilateral crossbite. While this one is involving all the arch or bilateral sides, so we call this as a bilateral crossbite because it's involving both sides. The most important part when you have a crossbite, and whenever you have a crossbite, you have to examine the presence of displacement. So what does that mean? Displacement is called that the patient, when he closes, he will have a premature contact, that it will not make him feeling comfortable to bite food. So patient is trying to achieve maximum intercuspation, so he moved the mandible to achieve that. As we can see in this video here, if you can see, the patient has an anterior crossbite. So then you try to put the patient in the centric relationship, and he is biting cusp to edge. He's not feeling comfortable, so he's posturing the mandible forward to achieve this maximum intercuspation. Remember that the presence of such a displacement can cause damage to the labial surface of the upper incisors, periodontal recession of the lower incisors. So presence of displacement and could sometimes result in temporomandibular joint dysfunction. So the presence of displacement is very important to be detected, because if a patient is young and he has a crossbite with displacement, we should provide him with treatment immediately. This is another example of anterior crossbite with displacement. Yeah, you see how much is the teeth is displaced forward during the closure. Sometimes the displacement as well is not only anterior, sometimes it's to the right or left. If you can see this patient, the midlines are coincident. The patient now is biting cusp to cusp. Now what's happened, the patient is not feeling comfortable, so what he's doing is shifting the mandible to one side to achieve maximum intercuspation. Now when we want to describe this crossbite, we call it unilateral buccal crossbite with mandibular displacement to the left. That's how you should describe it. Now when you decide to treat these kind of crossbites, first, if you look at the lower photograph, you will be expecting or imagining that I have only to do expansion on one side, because the crossbite is only on the left. But in reality, because the patient has displacement, he's biting cusp to cusp. No, the maxilla is narrow on the right side and left side if you look at the top photograph, and we need to do expansion on both sides to correct this one. So that's why it's very important to detect displacement. And notice as well on the midline, in the lower, there's a huge shift in the midline. If you did not detect this displacement, then you can imagine that, oh, this is a midline shift that we need to correct, but in reality there is no midline shift, it's only due to the crossbite. So by that now we finished the examination lecture, and then we move to the second part, which is the treatment planning. Thank you very much. Hope that you enjoyed this lecture.